Hello, I'm Rick Boddy. I'm a professor of emergency medicine at the University of Manchester, and I do my clinical work as a consultant at Manchester Royal Infirmary. And this morning, I'm going to talk to you about airway. Now, I'm not going to talk about airway catastrophes, actually. I'm going to talk about how to prevent airway catastrophes by being up to date with the latest evidence. So I'm going to take you through evidence from the last few years that really can guide our emergency airway management. And we're going to start off with a very controversial topic, cardiac arrest. So we'll start with out-of-hospital cardiac arrests and that big controversy. Should we intubate patients in out-of-hospital cardiac arrest, or should we use more basic airway techniques? And to answer that question, I'm going to draw your attention to a really big landmark trial in the UK called Airways 2. So Airways 2 was led by a colleague of mine called Jonathan Benger, and he's from Bristol. And it was a big, multi-centre, cluster randomised controlled trial. So what do I mean by that? Well, it means that patients weren't individually randomised to one group or the other. In fact, they randomised paramedics. And so paramedics who were participating in the trial were randomised either to treat every patient they saw in out-of-hospital cardiac arrest by intubating them first, or to use a supraglottic airway. Now, they could cross over if they felt it was really necessary, but that was the approach they were asked to take first for patients with out-of-hospital cardiac arrest. And then the primary outcome was the modified Rankin scale at discharge or at 30 days, whichever one came first. And they dichotomized that into either a good outcome, so that's 0 to 3 points, or a poor outcome, 4 to 6 points. And the key results are here. They included over 9,000 patients, so fairly evenly split between the two groups. And the key result is that they found no difference in the incidence of the primary outcome. So there was a good outcome in 6.4% of the patients treated by a paramedic in the supraglottic group, and there was a good outcome in 6.8% of the patients who were treated by a paramedic in the intubation group, and that difference was not statistically significant. Now, you might think that you'd get more successful initial ventilation with endotracheal intubation. In fact, they found the opposite. You were more likely to get initial successful ventilation with a supraglottic device, 87% versus 79%. And you might think that patients who had a supraglottic device were more likely to experience a complication like regurgitation or aspiration. But they weren't. There was no difference. So we have here really convincing evidence that using a supraglottic airway is just as good as intubating patients in out-of-hospital cardiac arrest. There's no benefit to be had by intubating those patients. And in fact, we're more likely to successfully ventilate them initially. So let's move on and talk about pre-hospital intubation more generally. Obviously, there's more evidence around cardiac arrest than just the Airways 2 trial. And there are other contexts like trauma when we might intubate patients in the pre-hospital environment. Now, we have a really nice systematic review published in Pre-Hospital Emergency Care in 2021 by Carney et al. And I'd like to draw your attention to this one. So it's a big systematic review, including 99 studies with over 630,000 patients in those studies. And there were multiple comparisons that they looked at. First of all, they compared bag valve mask to supraglottic airway. Then they compared bag valve mask to endotracheal intubation. And finally, they compared supraglottic airway to endotracheal intubation. And the two contexts they looked at were cardiac arrest and trauma. And they did this for both adults and children. Now, taking cardiac arrest first, just like Airways 2, there's no difference in survival for any comparison. And in fact, in the intubation group, patients were less likely to achieve return of spontaneous circulation than in a supraglottic airway group. There was a tendency for patients who received supraglottic airways to have slightly worse neurological outcomes for one of the measures, but not the other. In trauma, there was no difference in survival between bag valve mask and endotracheal intubation. And once again, just like Airways 2, there was no difference in the rate of complications between any of these different options. There was greater first pass success with a supraglottic airway, and on the contrary, there was less inadequate ventilation with endotracheal intubation, as you might expect. So what does that tell us? Well, it tells us that there's no patient benefit to be had on an individual level from intubating patients in the pre-hospital environment in general for either cardiac arrest or for trauma. Now, that is a bit controversial, polarizes opinions. Now, I'm not here to give you the answer about whether you should or shouldn't intubate patients. There are different arguments. On an individual level, no evidence of benefit. On a population level, if paramedics are intubating patients with out-of-hospital cardiac arrest regularly, will they lose their skills? When they have a patient who really would benefit from endotracheal intubation, will they then have a worse survival rate because the paramedics don't have those skills? Well, those are arguments that we need to have, discussions that we need to have, but on an individual level, the evidence is clear, no benefit. Next, let's move on to intubation techniques. So let's move into the emergency department. Let's look at how we optimize our first pass success rate for patients that we're intubating. All of us want to be really good at this. We want to have fantastic first pass success rates. We want to be great at this technique of intubation. So how do we get there? Well, there's some evidence that tells us how we might be great at intubating. First of all, let's start with that age-old controversy. Should you use a video laryngoscope or should you use a standard laryngoscope? Now, if you watch podcasts or read blogs, you'll see that this standard direct laryngoscope was invented in 1943 and hasn't changed a lot since, whereas these funky new video laryngoscopes, surely they're going to be better, aren't they? Well, let's see. There's some evidence in this regard. Again, it's from a few years ago now, published in the Annals of Emergency Medicine from the National Emergency Airway Registry in the United States, where they included over 19,000 patients who underwent intubation in the ED. The vast majority had at least one difficult airway characteristic. And they looked at what predicted first pass success. Now, they did propensity score matching because, of course, those two groups weren't the same. It's not an RCT, it's a retrospective cohort. The patient groups have different characteristics. So they used propensity score matching to try and even that out. So basically, they're finding populations that seem to have the same baseline characteristics that might predict successful intubation. And therefore, we've got an evened out cohort. And in the orange box, you can see the factors that were associated with first pass success rate. Video laryngoscopy had an odds ratio of 2.2. It was one of the 4 factors associated with first pass success. The others all reduced your chance of success. So a visual impression that the airway might be difficult, blood or vomit in the airway, and interestingly, going into another controversy, external laryngeal manipulation, cricoid pressure, less likely to get first pass success. So this study seems to tell us that video laryngoscopy is associated with greater first pass success rates from a very big case series in the United States. But the benefit of video laryngoscopy might not just be greater first pass success rate. There are other benefits too. The team leader can see what's going on, and also we can save images and learn from them and do research on them to work out how we might get greater first pass success rates in the future. And last year we saw a couple of really nice papers that can teach us about what factors might predict our first pass success using stored images from video laryngoscopy. First of all, Driver and colleagues published this in Annals of Emergency Medicine from Hennepin County Medical Center. That's where this illustration is from. It was published in the paper. If you engage the median glossoepiglottic fold, which is shown here on this diagram, are you more likely to get a good view? So if you see in the picture, you see the laryngoscope in silver at the top, resting in the vallecula. Here's the epiglottis, and you can see in the middle, this median glossoepiglottic fold. So if you engage it when you're intubating, you get a better view. You might think it's intuitive that you would, but here we have some evidence to suggest that absolutely we do get better views. 96% got a good view compared to 87% if we didn't engage it. So just one to look out for when you're intubating. Try and look for that median glossoepiglottic fold when you rest in the vallecula and pull that forwards, and that will optimize your chance of getting a better view and thereby your chance of successful intubation. Moving on, Miller published this nice paper in the Emergency Medicine Journal. What's the optimal view during video laryngoscopy? Now, the primary goal of this study was to look at other measures. Like if you get a better Cormac-Lehane laryngoscopy grade when you're doing laryngoscopy, you're more likely to get first pass success. And you know what, you are. That's not really much of a surprise. But in an exploratory analysis, they looked at whether it mattered where the top of the vocal cords were on the screen when you started to intubate the patient. So we've got 5 quintiles of the screen here. The top of the vocal cords might be in the top 20% of the screen, as at the top left here, or it might be in the second 20% of the screen, or in the middle, and further, it might be further down. Does it matter where it is on the screen? And is it associated with first pass success rate? Well, it is. And in fact, if the top of your vocal cords is right here, see the orange box here? If it's in the second quintile of the screen, you had the best chance of first pass success, 86%. If it was in the bottom quintile, you had a really poor chance, and it gets slightly better until you get to this second quintile. That's where you want the top of the vocal cords to be on the screen at video laryngoscopy to optimize your chance of success. So, really nice evidence from a very simple study using video laryngoscopy airways. Lastly, let's look at surgical airways. Reason why it's last, it's our last resort, isn't it? We never want to have to do a surgical airway for our patients if we can avoid it, because it's such a difficult procedure and, of course, a pretty scary one as well. Now, fortunately, we have some evidence to tell us a bit more about what happens when we do surgical airways. The London Ambulance Service published 20 years of experience across their service, and there were 72 cases that they treated with surgical cricothyroidotomy during those 20 years. Now, most often they did that because of a failed intubation, 76%, and that was most commonly because of blood in the airway or burns with airway swelling. Sometimes they went straight to surgical cricothyroidotomy because the airway was inaccessible, or, for example, the patient had trismus and they couldn't get around that. Now, in the middle, you can see the mortality rate of surgical cricothyroidotomy. Now, about half of patients were already in cardiac arrest. 44% of the patients died on the scene. Another 44% died in hospital. And the survival rate was only 6.9%. So it was a procedure associated with a very high mortality rate. And that's despite the fact that 97% of those procedures were successfully completed by the London Ambulance Service. So it really is a procedure associated with a poor mortality rate. But this is a really interesting analysis from that same study. Now, pre-2005, the London Ambulance Service failed intubation protocol stated that you'd move on to a surgical airway if you failed to intubate and ventilate. After 2005, they started to use supraglottic airways, so the ProSeal for the first 4 years, and then later the iGel from then on. And that meant that if you failed to intubate, failed to ventilate, you'd put down the supraglottic airway, which would allow you some rescue ventilation for the patient, and thereby potentially avoid surgical cricothyroidotomy, buying you time to get a definitive airway. And you can see that after they introduced these supraglottic airways, their use of surgical airways fell dramatically. Now, there's a difference between cause and association, of course, so we can't be sure that it's a causal effect, but it's pretty dramatic. It makes sense. It's got face validity. Using the supraglottic devices seems to prevent the use of surgical airways, and given the poor prognosis with that technique, that's a good thing. So in summary, pre-hospital intubation, there's no evidence of benefit in cardiac arrest, no evidence of benefit in trauma. Should we do it? Remains controversial. Video laryngoscopy is associated with greater first pass success than direct laryngoscopy, and it's allowed us to get some evidence-based tips for success, engaging the median glossoepiglottic fold and putting the top of the vocal cords in the second fifth of the screen. Lastly, pre-hospital surgical cricothyroidotomy. It's got a terrible mortality rate, really high, but use has fallen since we started to use supraglottic airways as a rescue device for failed intubation and failed ventilation. Buys us some time and allows us to ventilate patients. Thank you very much for listening. It's been a pleasure. I hope that has been a useful tour of the evidence for airway management in the emergency department, and I hope to see you again soon. Take care. Bye.